Thank you again for inviting me. I was given a very large task, which is to talk about immunotherapy in ovarian cancer and some of the promise and what's been going on with it. It's an enormous plate, and I realized when I was getting started for this that I had like 3 hours of various lecture slides to pull down into 25 minutes. So I'm going to dive right in. I want to give you my conflicts of interest up front, and I will definitely be talking off-label today. I do want to put a little plug in for the place I work. I'm very proud of it. Moffitt Cancer Center here in Tampa, Florida. I came here when I was only 15 years old, and it's now the third largest cancer center, and it's poised to be the biggest one, I understand, within the next 10 years. We were the first nationally ranked program at our cancer center, and we're also the highest ranked program for GYN cancer at our cancer center as well. And this is the great group of professionals I work with that make it all happen. So, a quick overview for the immune system. I know we have a varied audience here, and so this may be a little bit of a refresher for some of you, and for some of you, it may be a little bit new, but you have two basic arms to your immune system. You have your innate immunity, which are basically cells that go around and fighting pathogens that they don't have to be specific for. And then you have your adaptive immunity system that goes around and adapts basically to fight things that it's specifically engineered to do because there's been antigen presenting cells that have showed it particles of what it needs to go after. And it goes to T helper cells, which then can either activate plasma cells to make antibodies or to activate killer cells that we also call cytotoxic or CD8 T cells. All of this is in a very confusing environment with these tons of different chemical messengers and different kinds of protein interactions on cells that modulate the therapy. But I'm not gonna try to belabor it too much, and this is going to be a pretty heady overview. It can get really complicated really fast, and so what I want to tell you is this can be daunting even for people who do this all the time. So I'm just going to be touching on highlights of things that I think are relevant for immunotherapy to ovarian cancer on many different ways that it's being looked at, and kind of tell you where some of the positive and some of the learning experiences have been. So is ovarian cancer an immunogenic tumor? In other words, does it provoke an immune response? Well, it's not a really hot one that provokes a huge immune response, but some of them do, and there's varying degrees. And if you look across genomic data sets, you can look for immune profiles you would predict to have low immune response, medium, or high. And this actually correlates out to what you'd think of in terms of cell types or expression of various proteins that are markers of immune response. And this correlates again with survival. So yes, there seems to be some relationship that we know between predicted immune response and ovarian cancer. So the question is, where's all the immunotherapy, right? And where are we? I've looked at a lot of schema, and they always come out with things that seem to be more immunologist kind of based in how they do it between active and passive immunity. But I kind of keep track in terms of things that are more like clinically relevant to me, which are targeted based immune approaches and non-targeted. In other words, non-targeted ones that support the immune environment so that way it can work better. I'll start off with immune ligands, which are basically proteins that bind to something, and the most common one is an antibody. It's basically like a spatula. You've got your handle at the bottom here, and that's constant for all of them. And then you have the adaptable part, which is down on the ends, which is what binds to things. And so that's what we call the variable region. So you can take these and you can stick on very toxic drugs to them or chemotherapies and more specifically target them to things, and that's what's an antibody drug conjugate. You can also make them to where they bind to two different things. And so a great opportunity there would be, let's say you have a cancer cell, and let's say you have an immune cell. You get them together in proximity, bind them, and you activate the immune cell, and it goes after the cancer cell. And that's what we call a BiTE or a bispecific antibody. And then you can take portions of an antibody and make drugs. We do that partly by taking off this variable region at the end. And you can do that and either make it into a CAR, which is where CAR engineering comes from CAR Ts. We use these fragments on the outside to bind to things. Or you can take various drugs or cytokines and you can attach it as well and have it go after cancer cells and get into places where they can't normally get to. And I'll be telling you about some stuff like that today. Lots of drugs out there called mAbs. Drug-a-mAb is basically anything that's a monoclonal antibody. We are not going to go exhaustively through this. You've been hearing about some of them already, but I'll quickly highlight that immune therapies have been out there for a while for ovarian cancer. And so one that you're all aware of is Avastin or bevacizumab, and it's approved in all lines of therapy. And people think of it as an anti-blood vessel drug, but it actually has very strong immune properties. You see high VEGF levels and things like ascites that are immunosuppressive, and if we give Avastin, it can actually modulate the immune response. You're also aware of drugs like pembrolizumab or dostarlimab. These are called checkpoint inhibitors that help re-release the immune system to attack cancer. And they have an all cancer indication for patients with certain markers who've exhausted other therapies. And then there's the antibody drug conjugates, mirvetuximab. For those of you who were listening earlier to Katie and others, you heard that. And then there's also trastuzumab deruxtecan. So let's just talk about simple antibodies and how they're used. One very attractive target for an antibody was originally thought to be CA-125. That's that same protein that's looked at when you get your blood test for ovarian cancer. And so John Barrick over 20 years ago published this trial, which was a negative trial, but it looked at giving this as an antibody against CA-125 after patients had received chemotherapy. And even though it was a negative trial, it turned out that when they looked back at patients who had something called minimal residual disease, which I think you heard from Dr. Rezvani earlier was kind of a good sign of where immunotherapy may have its best opportunities, it looked like there was a benefit in those patients. They also looked at it in different kinds of scheduling, whether it's better to give it with or after chemo. And they took that information and did a randomized phase 2 trial that seemed to support that minimum residual disease population. And that has turned into a phase 3 trial led by my friend Angela Secord. And we'll have to just wait for the data to see how this turns out. The similar thing was seen for an antibody that attacks folate receptor alpha. And so this was based upon an earlier trial that was also negative, but they looked back and saw again the minimum residual disease principle. Unfortunately, when we did the randomized phase 2 trial on this one, it turned out to be a negative study. We'll switch over just briefly and touch on antibody drug conjugates. I know you've heard a little bit about that if you were here earlier. Probably the two of the biggest ones that I think have made some news recently are trastuzumab deruxtecan, which is after HER2, which is normally thought of as like a breast marker or something like that. But in the 40 patients with ovarian cancer in a phase 2 trial, about 1 out of 4 of them had very high expression levels of this, and the response rate was almost 2 out of 3. It wasn't too shabby in the other patients either. And it's being developed in various ways. And if you listen to Dr. Moore earlier, you probably heard about that. Mirvetuximab also is an antibody drug conjugate, but this one's to folate receptor alpha. And of course, folate receptor alpha is a recurring theme that you're hearing a lot, and you will hear more about as I speak about other approaches. But this got approval based upon its comparison to single drug chemotherapy for platinum-resistant cancers, and it improved both progression-free survival and overall survival. But of course, the problem with mirvetuximab is that activity seemed to be mainly in the 30 to 40% of patients who had very high levels of expression of that. And so building on its heels are several antibody drug conjugates that don't seem to have that same requirement for high levels of expression of the folate receptor alpha in ovarian cancer. And of course, I'll plug the one that I'm working on. This one happens to be by Eisai, and it's MORAb 202. This one was in an early phase 1 trial, and it had pretty good activity. But what was special is that the activity didn't seem to be limited to a folate receptor alpha expression. There are other ones out there. I heard Rena S earlier when I was logging and stuff like that. There are other ones out there that also seem to have less dependence on that. And so Vicky Mocker and I are currently writing up the phase 1 on this, and I'll have a poster up there at AACR in Boston. We'll be talking about the launching phase 2 trial for platinum-resistant ovarian cancer. I'm going to switch over to bispecific antibodies. These are also known as BiTEs. There was an early BiTE that had really great activity, and it did both the anti-VEGF, which Avastin kind of holds on to, but also held on to something called DLL4, which has both blood vessel growth properties and immune modulating properties as well. Had some really spectacular responses in heavily pretreated patients, and even had a biomarker for angiogenesis that looked to be correlated with that. Problem was pulmonary hypertension was an issue, so it kind of thwarted further development. But it hasn't stopped the interest in this, and there are companies like Regeneron who have bispecific antibodies that are both going towards the CA125 muck protein and also to stimulatory domains on the immune cells, and combining those with checkpoint inhibitors, and that's ongoing at this time. How about some novel uses of antibodies? This is my disclaimer. If you're someone who's queasy, I tried to edit out as much as I could of the surgery, but there's a picture of surgery in here. Close your eyes. It's just going to be for one slide. So this was a phase 2 and then phase 3 study that we did to get FDA approval for something called Cytolux, which is a folate receptor alpha antibody, but tagged not to a drug this time, but tagged to an immunofluorescent marker. And given right before surgery, we were able to use a near-infrared camera, and in 1 out of 4 patients, we were able to detect clinically significant disease we would have otherwise not taken out by using this camera system. Another novel use for this is instead of putting on a fluorescent marker or a drug, you can put on a radiation particle, one that has very superficial but high alpha emitting particles on it. And Dr. Vergote asked us to partner and be a US site in doing this trial, and it's for initial diagnosis of ovarian cancer patients after their interval debulking surgery. We administer this. So if anybody is interested in this, please feel free to get a hold of me. I'm going to be switching over to vaccines. This is a complicated slide. Let's just say that there's 2 primary ways that vaccines have been looked at so far in ovarian cancer. There's others, but 2 primary ones. One is when you take out immune cells and you stimulate them with either whole tumor or you stimulate them with parts of tumor, and then you inject those back in the lymph nodes. And the other way is when you take the actual parts of tumor that are little proteins that are there, manufacture them, and then you inject. A randomized phase 2 trial that was looking at folate receptor alpha peptides. Again, you're hearing folate receptor alpha. We took peptides of those patients, and after they had a response to platinum-based chemotherapy, we did a randomized trial. It was a phase 2 trial, about 120 patients. And unfortunately, in this one, we did not see significant activity using these peptide vaccine by itself. Another disappointing result for us was a dendritic cell study that was published by Rod Riccone. This one was taking patients' tumors, making autologous or their own type of vaccine. It had a plasmid in there that suppressed certain things that suppressed the immune environment and enhanced it in other ways. But unfortunately, it was a negative trial overall. But when they looked at subgroups, it looked like patients who have normal BRCA or non-mutated BRCA may actually get some benefit. There's more on this to come. There's more vaccine studies out there. It's a little bit too much to talk about at this present time. I will just say that generally they have been safe, but the efficacy is really what's kind of held them up. Personalized vaccines probably are a better approach than the peptide vaccines. Ones that are engineered in combination with other immunomodulatory agents are probably the way to go. And I'm very interested to keep my eyes on this preventative vaccine that's been announced in development in the UK, where they're screening for peptides that are associated with early ovarian cancer and planning to do a vaccination trial, first of all, in high-risk patients. So we're going to switch over to adoptive cell therapy. Now, adoptive cell therapy comes in 2 different flavors primarily, but it's really the same thing. We take immune cells, we grow them up outside the body, we give the immune cells back after typically suppressing the other immune cells that were in the body before, giving the concentration of the ones that we want to have present. One of these is called TIL, or tumor infiltrating lymphocyte. And what distinguishes this one is we get those immune cells out of the tumor itself. So you take them out of the tumor, you grow them up, you give them back to the patient after you've suppressed the other immune cells. The other way is where you take immune cells out of the blood and you engineer those in some way to go after a specific target. And you'll hear various terms like CAR and TCR and CAR-NK and CAR-T. Just to know that they're all engineered cells that are going after typically a very specific target that we think is relevant. We know that higher presence of immune fighting cells within tumors is correlative to survival. And the question is, how do we make immune cells go to tumor, and how do we make them active and stay there and fight cancer? There's been several TIL studies with ovarian cancer patients. Unfortunately, most of them are mixed into other solid tumors. Some of them are just very small proof of concept. Some have been mixed with chemotherapy, making things like response rates of 86% very difficult to interpret. But just know that in general, there are some problems with TILs that we've discovered that we have to overcome. We know it's feasible and generally pretty safe to do TIL, but very limited in how long they stay around. It's very limited on how long they're active against the tumor. There's a lot of immunosuppression we have to learn to overcome. We're going to have to start doing engineering things to put constructs in them to keep those active. We need to combine those with different agents that might do that, which is something I'm very interested in, and we'll talk about that later. Patient selection and timing of when you do these things matters a lot as well. One of the things that's really been hard for it is the manufacturing process. So I'm working on a patient today. I'm still trying to figure out how to get her TIL scheduled, because these have to go off to special labs. They can only process so many of these at a time. It takes a couple weeks still to grow them up. And so between doing surgery and all that kind of stuff, it can delay someone's treatment sometimes to where they don't feel comfortable doing that. I'll talk briefly about CAR therapy. CAR therapy, which is CAR T, if you want to think about it that way, that means T cells. Specifically, there's also CAR NK that you heard about earlier from Dr. Rezvani. But CAR therapy has been enormously successful in some blood cancers. But there's some big difference between blood cancers and solid tumors. And so one thing is that we don't have like single markers that are on all the cells that are easy to wipe out all the cells. So there's a lot of heterogeneity or different variable levels of different types of markers, and a lot of overlap with normal markers that we might have elsewhere. Other thing is you have to get it there. So in the blood, it's easy to give a blood fighter into the blood where the blood cancer is. With solid tumors, you have to get them trafficked into the tissue. And then this actually is one of my patient's tumors over here on the right, by the way. Those red cells are the immune cells within it. And then we have to overcome an immunosuppressive environment. So once they get there, there's a lot of things cancers do to make that more difficult for those cells to function. I'm only going to talk about a couple of the problems and how they're being addressed. One of them is, how do you keep these things around, and how do you keep them active? One of the ways you can try to keep them more active is you can modify the receptor that you have, especially on the membrane side that's within the immune cell itself. That's the part that activates the immune cell, because the outside, this other side here, just binds to your target. This side has gotten further and further complex as different generations of these have been developed, and they started adding more stimulatory domains and even the ability to make their own chemicals to keep them active over time. This was one of the few completed CAR T studies looking at a target named mesothelin. And this one actually highlights the problems of persistence. Here they had to keep giving multiple doses to these patients. And you can see that while first these cells go up, over time it goes away fairly quickly. And they had very modest terms of just stable disease for months. Another problem is making sure you target tumor and you don't target the normal patient tissue. Lots of different markers looked at. They all have variable levels of selectivity for cancer as compared to normal tissue. And this is something I think that we have maybe a window for. I've been working on follicle stimulating hormone receptor CAR T, and the great thing about it is it's highly specific for ovarian cancer. So about 70% of patients will highly express this on their ovarian cancer. And if you look at normal tissues, the only place you find it, other than a teeny bit in the thymus, which is really not relevant, is you find it on ovaries and testes, which are obviously not a problem for the patients that we're treating. And I just saw my third patient on the fourth cohort today and took out her catheter, and she seems to be doing really well. And so we continue on with a relatively well-tolerated therapy. Another way that you can reduce all these off-target things, it's kind of clever. There's a company out there named A2 Bio, and we're working on this trial with them. But they're taking the approach of actually putting a blocker on their CAR T, where if a normal cell still has and retains something called human leukocyte antigen there and hasn't lost it, it will not activate the CAR. But if it's going after the mesothelin target and it doesn't have the HLA, in other words, has loss of heterozygosity, then it will attack. And so we're screening patients that both have a specific HLA type and have loss of heterozygosity in that. Unfortunately, these kinds of methods are very complicated, and only 5% of ovarian cancers are going to have that. But if you have that, we'd be enormously happy to talk to you. All right. Another set of problems that are seeking solutions are both getting rid of toxicity of doing these therapies and also the ability not to have to do the manufacturing process, in other words, using off the shelf. I'm not going to talk too in depth about this, but there's this new class of CAR T cells called gamma deltas that are being worked on, and the CAR NKs that you heard about before. These things can be off the shelf, which makes it very convenient. They have also some natural innate killer activity beyond their CAR activity, and they have lower risks of these special syndromes that go along with cell therapy, sometimes called cytokine release syndrome and immune cell associated neurotoxicity. This is not meant to be exhaustive, but if anybody's getting slides, I just kind of made a compendium of some of the new trials that are going. I'm going to switch over and talk about non-target based things to help the immune system fight. Number one, cytokines. These are chemicals that are released in the body, or we can give as well to activate the immune system. IL-2 is a particularly potent one, and it used to be used in renal cell cancer and melanoma. And quite frankly, I was reading a journal article in SITC last year where the author said that those that they gave that got in a complete remission could be considered cures. Unfortunately, patients died on trial because of the overwhelming immune response that would happen to just IL-2 by itself. So this company made a safer IL-2 by putting a blocker in it for the receptors that are not wanted and having it bind to the receptors that it did, and had some pretty interesting early phase data that went into a phase 3 trial. And unfortunately, just this year, we got news that the interim analysis on survival was going to be futile, and so therefore that one was discontinued. However, there's other cytokines that are quite interesting, and one of those that I like is IL-12. There's IL-18 and some other ones I think that have a lot of promise to this. I've been working with this company as a study chair to work on this molecule that again has that variable region of the antibody here. It has a special albumin binding domain, so it doesn't release in the blood, so it doesn't cause that toxicity. So it makes it much more safe for this to be given. And the great thing about it is it gets across areas where antibodies are hard to get to, and it concentrates in areas that's high in something called SPARC, that's secreted protein acid rich in cysteine, and that happens to be really high in ovarian cancers. So we have this ongoing phase 1 trial. This one has already passed now 6, where we're going higher because we just haven't seen the toxicity that you would expect, and we've started to see some responses. Switching over to checkpoint inhibitors. Now, this could go on for its own talk, but I'm not going to. There's just lots of checkpoint inhibitors, and I'm only going to talk about some relevant stuff. Quickly, I'll just say checkpoint inhibitors by themselves have not been effective. It's about 10 to 15% response rate. Combination checkpoint inhibitors, not much better, except with the notable exception of the recent data on clear cell, where there it went from 14% to 33% response in a trial that combined 2 of them together. Checkpoint inhibitors combined with chemo, VEGF inhibitors, PARP inhibitors, etc. It would be way too much to talk about in this talk, but I'll kind of give some representative examples of what I think is interesting. One is the Forward-2 study that recently came out, which unfortunately, when mirvetuximab, which is the folate receptor alpha body drug conjugate you heard about before, when that was combined with immune checkpoint inhibitor, pembrolizumab, it didn't really have better activity than we would expect with mirvetuximab alone, quite frankly. But it may be that what you pair these checkpoint inhibitors is critically important. And there are drugs that if you give them in small divided doses, it changes the way they work. These chemotherapies can be repurposed because it'll bring in anti-angiogenic or blood vessel properties and immune modulatory properties. And a couple phase 2 trials have kind of demonstrated some higher than expected response rates for these patients. And Merck reviewed that data and decided to open up the study B96 that recently completed. And there was a press announcement that for platinum-resistant ovarian cancer that improved progression-free survival in all comers and improved overall survival in those with PD-L1 scores greater than 1. We'll hear about more of that probably next month when it gets presented. Last thing is the tumor microenvironment. So uh, classically, bevacizumab, that anti-VEGF, it's not just against blood vessels, but it actually alters the way the immune cell functions. Another an example of this that was successful recently was the blocking of serum cortisol by relacorilant. And this particular drug was combined with nab-paclitaxel and compared to nab-paclitaxel by itself and demonstrated superiority in terms of overall survival. Other things that are being looked at. Well, it turns out things as simple as the aspirin or Tylenol you take may actually alter the immune environment and promote better longevity for patients who develop ovarian cancer. Now, I'm not saying go out and take this. I'm not saying the data is robust enough, but we had both preclinical data and there was a large epidemiologic study that showed patients who took that had better survival. So we are trying to look at the tumor microenvironment in patients at interval surgery who have been randomized to COX inhibition or not. Metronomic chemotherapy was one of my first interests in the timing and sequencing of different agents when I was a young faculty member. And so I continue to work on it today, but now I work with a group of mathematicians where we're taking various drugs and we're trying to do mathematical modeling based upon both patient information and preclinical work. And so there's more to come on how we might be able to combine immune drugs with traditional chemotherapies. So where do we go? I'm finishing up here. Well, we got to figure out how to make tumors hotter, right? So we got to make it to where the immune cells want to go after them. And then quite frankly, we have to make the immune cells able to go after them and stick around and continue to do their job. It's easier said than done, but I think you've gotten the theme today. I just want to kind of leave it with this last cool slide. I'm going to credit Aaron George, who works with me, and also Greg Sawyer, our chair of bioengineering. Here's how we're going to make progress, though. There's just too many different ways we can combine these things to have patients be the quote guinea pig in those things. That's just, we have to be very thoughtful before we bring something to a clinical trial on why it's going to work and that we have data. And so there's better ability now to study some of these immune drugs because studying an immune environment is different than studying a cytotoxic drug that just works on the cancer cell itself. And so we have cancer cells and immune cells that can be co-cultured. We have 3D microtumor things that are in these special Darcy plates that we can continuously perfuse and keep alive. Here's down on the left-hand corner, there's a patient of mine. Those little red cells, again, are her immune cells in there. We can study these in patient-derived xenografts. We can see that there's persistence of some of these things that we look for in the complex architecture. And what you're looking at in the right-hand side is a really, really cool time photograph of an ovarian cancer cell in red. And all those little squiggle cells are ones that are CAR T therapy. And I can't tell you the target at the moment, but these are going after a particular target and they're killing that cancer cell right in front of you. Thank you for your time. I appreciate it. And I hope I stayed somewhat to time.